Very nice to meet you. My name is Dr. Rami Haidar. Thank you for having me. Dr. Danny, thank you for inviting me. My fellow audience, my fellow colleagues in the clinic, it's an absolute honor to be with you today. It's always very challenging to catch attention whenever we talk about anatomy. Someone said anatomy is the grammar of medicine, which couldn't have been put in a better place. So I tried, and if I am to speak about anatomy, it's going to take of the head and neck area. It's going to take me for the next 2-3 days in detail. So I'm going to try and apply the anatomical things that we need to know about in the field that we do. When it comes to botulinum toxin and fillers, there has been a lot of names put into it. The best name I like was anti-aging medicine. And in order to treat a problem, we need to understand the cause of it. And we have to be realistic with our patients, because we could never change a 50-year-old to a 40 or a 40 to a 30. But our job is to change a 50 into a healthy 50 or a 40 into a healthy 40. And in order to know that, we need to understand the factors affecting aging and how does aging happen. So this is 3 generations. This is my son, myself, and my father. Those are our passport photos. And I think I've tried representing aging. And I attended an event once where they asked a sculptor to make a 27-year-old gentleman, and they sculpted a 27-year-old gentleman. And then they said, we want you to change this 27-year-old gentleman to a 50, but there's a catch. You're not to remove any clay, and you're not to add any clay. So all they did was they moved the clay from one place to another. So we slowly started understanding anatomy, where volume changes from one place to another and then finally goes down. So now we understand that aging has to do with volume loss. We lose the volume, and that's why we end up with a little bit of lines and wrinkles. But what are the factors? Where are we losing the volume loss? Because that's what we need to replace. If we understand what happens, we'll understand how to replace it. The main 3 factors that comes in when we talk about volume loss is, when it comes to aging, is bone aging, muscle aging, and fat aging. With time, the bone formation changes. The osteoclastic activity changes. So you have, when we're young, we got more bone deposition. As we get to a certain point, we have the same amount of deposition and resorption. And later on, we have more resorption. But just to make our life harder, each part of the face behaves in a different way. So the frontalis because the more superior we go, we need to respect the thickness of the skin, or when we're doing dermapen, mesotherapy, etc. The second layer is the subcutaneous tissue. This is the superficial fat. It acts as an insulator, by the way, where it helps in regulating the body temperature and anchors the skin to the underlying tissue. For those of you who work with threads and thread repositioning, this is the layer you need to be in. And this is the layer where it comes in as balloons, and we gain it and lose it as we're gaining and losing weight. After that, we've got the SMAS layers. SMAS layers are quite important, especially when you guys are doing addressing facelifts, because this is the first superficial muscle layer. That after that, we get the rest of the tissue. Now, we need to respect the function and the way the muscle moved in the face before placing our products. If you look at the Oscar red carpet in 2010, everyone who was smiling, whenever they smile, the fillers push upward and they end up with smaller eyes. Lips, for example, when they were done, for that Instagram post, they look fantastic, but the minute the patient starts speaking, the fillers spread out. So we started slowly understanding that we need to place our products respecting the muscle movement, especially in dynamic areas like the mid-face cheeks and the lips. The retaining ligaments is a hot topic now. I've got good news and bad news about it. There's not enough research till this day talking about retaining ligaments. Retaining ligaments are connective tissue that extends from the bone, goes straight out to the skin. They're very important in the contouring, and they're very important. They play a huge role when sagging happens, because they start becoming loose. If we had X-ray eyes and we knew where they exactly were, it would be fantastic, because we'd be placing our products underneath and we'd be lifting it straight away. So the bad news is there's not enough research. The good news is if we have any residents in the house, I would strongly recommend investing in those papers and the effect of what we do as far as collagen biostimulators and their reaction, what they do to ligaments. Finally, we've got the deep fat compartments. They work like a gliding scale between all the tissue and bone. Now, going back to the bone, the structure of the bone is very, very, very strong. And as they change, the density of it, the frontalis is different than the mid-face, different than the lower face. But the cool thing is, with the respect of anatomical landmark, if we could place our fillers deep on bone, the bone will be a pivot in order to lift everything upwards. Now, this is all good news. Now we're going to start, I'm here now to scare you a little bit when it comes to the vascular anatomy of it. The vascular anatomy, I'm pretty sure we've all studied anatomy very well, but we studied it in books, and we know a two-dimensional solution, but for a three-dimensional problem. What we do on a daily basis, we need to think of the depth and which part of the face is a major blood vessel in order to avoid it, and accordingly choose the technique to it. So I'm going to speak briefly about each third and what we need to worry about. And I hope everything I'm going to speak from now on is something that I practice I do in my own practice. It's not the only right way. I'm pretty sure everyone has their perfect way. And this is me just trying to avoid any conflict coming up. So with the upper third, the main indications is the forehead and the temple. What we need to think of when it comes to the forehead and the temple, let's start with the forehead. We've got two very important bundles. We've got the supraorbital and the supratrochlear bundle that comes out. Now, we know that the supratrochlear and the supraorbital comes out straight from bone, and we could see it forming how it comes out from the glabella. But where is it? How do they travel? What's their track? Because are they under the muscle? Are they over the muscle? Because if they're under the muscle, I'm going to inject over the muscle. If they're over the muscle, I'm going to inject under the muscle. Now, in order to achieve that, we've split the upper forehead into 3/3, an upper 2/3 and a lower third. The upper 2/3, I know 100% that those arteries travel over the frontalis. The lower third, it varies a lot. Do they go in 90 degrees? Do they go in 45 degrees? I don't know. So therefore, if I am to inject in this area, I would only choose to inject in the upper 2/3. I would avoid injecting in the middle third because I'm going in blind, and variation, even though I know that the injection, that the arteries are popping out straight from bone, I don't know if they're going out at 40 degrees, 45 degrees, 10 degrees, are they going on bone and then popping out? So therefore, in that area, I would definitely choose to inject only the upper 2/3 deep under. Now, I have seen, unfortunately, cases that here, this is a gentleman who had his glabella injected in a hotel room by a physician, or what they say the physician, and what they reported that day, they injected very, very superficially, and this is the patient 24 hours. We were lucky enough to be able, at Skin Experts, to save this guy's forehead, to go move it back to normal. But the whole thing started by, the biggest mistake was injecting in an area where it could be dangerous to inject. And not only that area is dangerous as far as we're going in blind, that area anastomoses with arteries that are responsible for our vision. The temple fossa is one of the most debated techniques I've ever had to I see, because what's debatable whether to inject superficial or deep. What's non-debatable is which level. If you are to inject superficially, the injection level should be between the superficial and the deep temple fascia. And over here you can see, as the superficial temple fascia is being raised, how the superficial temporal artery is running. Personally, I find it really hard to get to that level. And if it's not injected, this slides all the way down to the coronoid process. So if you are to choose that area, you inject it in that area. However, I'm a big fan of doing the shotgun technique, where I start off by drawing. And the cool thing about this technique is, The fact that you place it, I start off by drawing the superior, lateral, and the border of the temporal. I go in on bone, and by placing a bolus, it will slowly slide down and fill the whole area. Another case that we had to deal with, that was injected the wrong way. And because the injection technique was supposed to be in the technique was trying to be injected superficially, the hyaluronic acid fillers slid down to the cheek, and this is what the patient ended up with. So, and first we didn't know what it was. I sent the patient for an ultrasound. The ultrasound came back, and a scan came back as hyaluronic acid. By placing hyaluronidase in this area, we managed to break it down. The mid-face is a tricky one, because I always explain the mid-face, the infraorbital bundle comes out and spreads out like a tree. And what I find is most of the complications we deal with in the mid-face are delayed complications, which means it's more of a compression rather than intra-arterial. So therefore, rather than placing a huge amount in one area, I would strongly recommend injecting it in a sandwich technique using a cannula, where we place small amounts across different layers. Therefore, when the hyaluronic acid or the product is going to expand, it won't affect it. And here it shows very well how the infraorbital foramen bundle coming out and branching in different techniques, in different layers, sorry. The chin and the jawline, when we talk about the lower third, every single one of us knows that the facial artery extends from the external carotid artery, travels in a zigzag way, splits into the inferior labial artery, superior labial artery, goes up to the lateral nasal. I'm pretty sure everyone knows this, up to the lateral nasal, and then anastomose. However, what we didn't study in books, which level it goes. To make our life harder, there was a research that said even that there's plenty of different ways of a different variation of how it's spread. So therefore, but I do know that it becomes superficial, and in most of the cases, in the middle and in the upper third. So therefore, I tend to inject more or less in quite deep on bone. Now, this is a photo I took from a very good colleague of mine, Sebastian Cotfana, that shows a really good dissection, the marionette line, and how the tissue condensation is different between anterior and posterior to the marionette line. But always remember, again, there's no such thing as safe area, because this is a chin that was injected deep and unfortunately ended up with necrosis, well, the start of necrosis. Take into consideration the danger triangle and treat it very respectfully, because that danger triangle isn't only that could cause infection in the cavernous sinus, but the arteries in those areas, the arteries on the side here are very superficial. So therefore, personally, I would avoid injecting in the lateral nose area at all. The labial artery varies. We've studied in books that the labial artery is always behind the mucosa. But again, another research showed that in 80% of the cases, that's the case. But the labial artery could be within the muscle and could be more superficial. So the best sign of injecting in such areas is blanching, number one, and placing little amounts in different places. This is a case that we had to deal with. A colleague of mine, one of the most professional, experienced, well-educated physicians, called me while I was on my way to the beach. I had to come and attend to this patient. This is her before, middle, and yesterday I called her to send me a photo of how it looks now. But this is after 24 hours after lip augmentation. Remember, if you have a hammer, it's not always, not everything is a nail. So remember that, now understanding that the cause, we could treat problems accordingly. Always consult with your team. Have a good team with you in order to take opinions. There's no harm in doing that. And treat according to cause. For the marionette lines, for example, not only use the fillers, treat the DAO with botulinum toxin, treat the sagging with energy-based devices, and then treat the tissue display, and treat the muscle and treat the uneven loss with derma fillers. So think outside the box. Treat the problem according to the cause in order to get the best results. One with zero complications, one with zero experience. What differentiates us from everyone else is that we know how to treat the complication I'm pretty sure that at one point of our career, we're all going to end up with a certain complication, but it's the scientific background we have that's going to help us with it. Thank you very much.